University in New England, New Hampshire. He received his PhD in counseling psychology from Pennsylvania State University and his master's in clinical psychology from Western Carolina University. Prior to joining Antioch University, New England, Dr. Fauth was an assistant professor in a doctoral program in counseling and school psychology at the University of Buffalo. Jim is now the director for the Center for Research on Psychological Practices and is here to talk today about the development and pilot testing of a reading-based assessment tool that will be used to evaluate some community interventions. So Jim, feel free to take it away.
Okay, thanks, Samantha. So I'm going to provide an overview of the development and our pilot of this particular tool, and then we will open it up to questions and discussion. And again, I'm a faculty member in a clinical psychology program, but direct a center that does a lot of community-based evaluation work, mostly in behavioral health, but also in community health settings. And it's really primarily around the community health evaluation work that I'll be speaking today. So let's see how I can forward this slide. Here we go. So the context in which we developed the tool and are currently using the tool is within an initiative called Healthy Monadnock 2020, which is a healthiest community initiative in the Monadnock region of New Hampshire. If you look at the map, you'll see the Monadnock region is in the southwest corner of the state, and the main population center is Keene, which is where I'm located, and Cheshire Medical Center, which is the backbone organization for this collective impact initiative, is here. Keene's a small city, about 25,000 people or just under that. And Peterborough is another population center. So it's a fairly large area for a collective impact initiative and a fairly dispersed rural population. So when I was contacted by Healthy Monadnock to serve as evaluator, one of the challenges was to think about how do we evaluate a project like this that is very ambitious in reach and scope. So if you can see, this is kind of a simplified version of the logic model for the project. And you can read it like as you do most logic models, going from left to right. And when I came on board as the evaluator, they were developing the project, and mostly in a planning phase. And the local hospital, Cheshire Medical Center, is considered the backbone or the kind of hub of the organization. Has a couple of staff people that are really the only paid staff directly through this project. And they do their work with external stakeholders and the community around multiple areas, multiple strategic pathways that are designed to improve health access and quality, health behaviors, social determinants of health, and social capital and connections at the community level, all of which are designed to promote health status and make the community the healthiest in the country. And you can see this logic model is pretty simplified, but essentially there's pathways that involve a set of strategies. So in the top row you can see healthcare strategies, various strategies that the initiative has deemed to be the ones that are have the most leverage for promoting change in the healthcare domain. Then the initiative seeks partners, sometimes coalitions, sometimes organizations, to help actually take on and implement those kinds of strategies. And then those partners ultimately implement. PPP stands for programs, practices, or policies, and to actually try to make community health improvements. And so within each one of those pathways, there could be a very large portfolio potentially of different kinds of PPPs or intervention. I'll just use the word intervention. And designed to promote, to kind of move different levers and promote health status. So when I came on board, this was kind of the model that they were proposing and beginning to use. And the primary kind of evaluation tool at that point were what you might consider outcome and impact indicators. So these are kind of surveillance level existing epidemiological indicators of things like food consumption and rates of diabetes and things of that nature. So some of which we think of as more being in the health behavior or the outcome bucket, things like various health behaviors and rates of smoking and drinking, and then things like diabetes or BMI status and things like that, which we would think of as health status indicators. So this was kind of the challenge for me to think about and my team to think about as evaluators. So we basically dove in by doing what's probably the easiest stuff first, which is to think about how do we assess and evaluate some of the work that they're doing around capacity building with community stakeholders and development of partners to implement these strategies. And you can see a few different tools there that we've used for that: survey of the community, a community readiness assessment tool, and a social network assessment. Those aren't the topic of the talk today, so I'm just going to skip over those. So we did the easy stuff, and then the problem became, essentially we had very proximal indicators of the work of Cheshire Medical Center as the backbone around capacity building, and then we had these very high level regional indicators, but we didn't really have any way of assessing the nature, quality, intensity of the various programs, policies, and projects that were beginning to hit the ground, that were beginning to be implemented in the community. And that's a real problem for an initiative like this, which has really lofty goals, and where we know it's going to take a lot of activity to change those kinds of epidemiological indicators at the county or at the region level, and that they were not very good proximal indicators for the initiative to be keeping their eye on in terms of what they were more directly producing. So the next step in the development of the evaluation was really to think about how do we assess in some meaningful way that might actually ultimately predict the degree to which these health indicators might move. How do we assess what's actually happening on the ground in terms of programs, policies, and practices? So it's kind of a pathway in trying to think about the development of this REAIM tool, and to fill that gap. The first decision was really thinking about conceptual models that could help us kind of think through this, and the first decision we made around that was to think that REAIM was a useful model to think about the potential impact of any kind of health intervention. And the program, the initiative itself, was already using a collective impact model to guide the initiative. So those were two kind of guiding conceptual models. We liked a tool. We imagined that we could build something kind of similar to a tool we had used before, that's the purpose of which is to assess community readiness for change, because it seemed to have the kind of flexibility that we would need to be able to assess widely varying programs, practices, and policies. So essentially, we needed a tool and a way to assess interventions that could be almost apples and oranges, very, very different kinds of interventions that all might be happening under the umbrella of health and Monadnock. So that was kind of an inspiration tool. And then I found my way to Samantha Harden as a REAIM consultant and someone who had done some measurement already around REAIM when I found that there wasn't an existing tool that we could use and that we would have to develop something. And Samantha and I spent quite a bit of time kind of going back and forth developing the first few versions of the tool. And right about at the time I thought I had it settled, I went to American Evaluation Association presentation and saw a presentation on something called what the presenter called an intensity tool, which was a kind of pared down version of what we had been developing, but had a couple of really interesting qualities that we decided were really worth integrating into our tool. Some of their indicators, but also the scale for the ratings. So we've incorporated those in the version that we're at right now, and a colleague of mine, Megan Edwards, helped me kind of make the finishing touches on the current version of the tool that we're using and have piloted, which we're referring to for now as REAIM Plus 3.0, just in terms of our development. And if anyone's got a better name, I'm all ears for that. All right, so most of you already know what REAIM stands for. So the only thing probably new that we've introduced here is the plus part, which stands for synergy. And that's really a nod to collective impact. So not only are we trying to assess the reach of the various interventions, the actual or at least potential effectiveness, the level of adoption, the quality of implementation, and maintenance of the interventions, but also to what degree are they aligned with the overall goals of the initiative and aligned with the strategies? Are they consistent with the strategies? And do they actually contribute something unique? Obviously, if any given intervention within a portfolio of interventions is completely redundant with another one, it's not all that helpful. All right, so that's kind of just an overview of what we wanted to capture with the tool. And why assess it? One, we wanted to provide the initiative with a way to kind of keep their eyes on the ball. So on the key levers for community health change, and also to provide them with some, to make more visible to them how those might be improved, or how the potential impact of those could be improved or scaled up over time. We wanted a more proximal measure of the kind of public health intensity of what the initiative was producing over time. We wanted to place very different programs and policies and projects on the same metric or scale so that we could compare among and between them. And ultimately, we'd like to relate the level or kind of the overall REAIM characteristics to the ultimate outcomes to make a better case that Healthy Monadnock is actually responsible for whatever changes occur over time. And having a tool like this facilitates comparisons over time and also across the different areas, the different strategies and the different outcome areas that Healthy Monadnock is investing in. So some of this may be a little too small for some of you to see on your screens, but this is the rating rubric or portion of the tool. So this is how we actually generate scores for each intervention. So if you look on the left-hand column, you'll see the scale or the kind of domain that we're rating. And then in the next column to the right, you'll see each particular item or indicator that essentially makes up the score in that for that scale or domain. And then you'll see the actual ratings. So it's a 5-point scale, but we use this is kind of one of the innovations we borrowed from the intensity tool, and the reference for that tool appears at the end of this presentation. One of the things we thought was innovative about that tool is that it's sensitive to score, and our original scale was I forget 1 to 5 or 0 to 4 or something like that, and it's a little sensitive to tell any community partners that their program or policy or project has no impact to score to 0. Or that really any such thing really exists. And so this was a way to kind of properly weight the level of intensity along these different characteristics of each intervention in a way that we actually thought was more fitting to what we're actually rating. So I'm not going to go through each one of these, but you can see them there, and I'm happy to send this out. So these are the items for reach, effectiveness, and adoption. And here you see the rest of the scale with implementation, maintenance, and synergy. So how do we generate these ratings? Who generates these ratings and how? Kind of multiple steps. So for each intervention, we get whatever documentation we can on that particular intervention from Healthy Monadnock staff, but also whoever the community partner is that's implementing that intervention, and basically read up on any kind of information they have about it. We consult as well the scholarly literature, especially to aid in our estimate of the evidence domain. And we follow up with key informant interviews to fill in gaps of knowledge. And so you can see this is, this is fairly crude inputs and fairly crude ratings. And all of these are done by student members of our team who go out and do the interviews and collect all this information and generate the ratings, and they're supervised by Megan or me. And this is just a listing of, the names don't mean much to you, but a listing of the different kinds of interventions that we included in our pilot testing. And here, so I wanted to show you just quickly a little bit, again, the particular interventions don't mean much for most of you, but I wanted to just show you a little bit of how we can display some of this data. This particular view is a way of depicting each intervention, and you can see they're color-coded by whether they're a policy, which is in the red color, a program in blue, or a project in the green color. And the size of each of the rectangles is reflective of the overall score on the REAIM tool. And in this case, we're comparing 3 different strategy areas: active living, healthy eating, and then interventions where they're really targeting both at the same time, that we couldn't separate it out. And in the case of Healthy Monadnock, that's where most of their interventions have started, and that's where the initial work has been. But you can imagine, as they continue and take on some of the other areas, that we'll be able to make comparisons about the overall level of or intensity of interventions across the various domains that they're trying to move. And so then the overall height reflects the overall level of intensity. That's one way to use these data. This is a display where we're showing by type of intervention, program, project, or policy. Again, that overall level of intensity. And you can see in this case that that overall, the policy domain or dimension has the highest kind of average scores on the tool, which makes some sense, with 2 of those being particularly promising. And this is also just a way to compare across all the various interventions and where they stand. So this is, a way to kind of sort and look at ones that are potentially achieving higher versus lower impact. Then, this is a little faded on my screen here for some reason, but then of course we can look at any individual intervention and its particular profile, reading profile. I don't have the synergy scale here because at this point there's not enough. Everything's perfectly synergistic because they're just kind of starting out. So here you can see the intervention called Farm to School and where it sits in terms of the various dimensions. And you can see that effectiveness is one of the lower dimensions. Reach is another one that has some potential to get moved up over time. Adoption is fairly robust. People are able to adopt this intervention. Maintenance is good. So if there was something that could be done potentially about effectiveness and or reach, this is an intervention that has some promise because some of the other characteristics are fairly strong. And of course you can look at any of the interventions in this way to get a kind of profile and see, first which ones you might be able to feasibly improve. And ultimately over time, lean toward the ones that show the most promise and invest more in those versus ones that may be inherently lacking in some way in one domain or another. So basically this is the whole purpose of this tool is really to keep our eye on this ball, which is the one that's kind of most proximal, and we hope is really a leading indicator of community level change as the program and the project begins to scale up. So before I guess I was going to show you one other view from an article, but I guess why don't I stop here and see if there are questions and discussion that folks wish to have.
Feel free to unmute yourself and ask Jim any questions or to type them in the chat box.
Can you hear me?
Yes.
This is Jorge Ramirez Garcia, Oregon Research Institute. I wonder what the community stakeholders' response is to the tool and the process. That might be kind of a big question, a fair question, but any taste of that would be greatly appreciated.
Yeah, that's a great question. We've just started sharing results from the initial pilot testing, and really only in one venue so far with a community advisory board, where some of the partners sit at that table, and they what I've found so far, I haven't if there's been any grumbling, I've not yet been aware of it. I think people get that these are important kind of characteristics to pay attention to. And frankly, part of the purpose of the tool is not just as an evaluation or assessment tool, but actually as a prompt or nudge to at least help keep these dimensions on the front burner for community partners as they actually choose and implement interventions. As for those of you that do community health-related work, most folks are pretty attuned to effectiveness and to a little lesser degree reach. But level of and quality of implementation, for instance, is one that is often overlooked. And so it kind of helps everyone have a common language and a common framework for thinking about interventions and their potential for impact.
Thanks for sharing that and for a great presentation. Thanks.
Thank you.
Was there something else that you wanted to share, Jim, before we continued discussion, or?
No, I realized I forgot to show references, so I was just going to put that up as we're talking here.
Okay. Anybody from the REAIM work group can ask a question? I'll ask one, Jim. So what do you see kind of being next, and were there any particular challenges beyond some of the things that you mentioned in the process?
Well, I think at this point the next step is to see to what degree we feel like we can make credible estimates of pretty different kinds of programs or interventions. And so far, that seems to have gone okay. It does, poses problems with just how different some of the interventions are to ultimately be able to rate them on the same scale. The other thing I think we're all looking forward to is being able to look at changes over time. So our current plan is to do this kind of assessment on a yearly basis. And in the AEA presentation that I mentioned, they had a few years of data, and you could see not just that the overall intensity went up, but what was one of the interesting things about that initiative is they actually, the number of interventions didn't increase across the years, but the intensity did. So essentially they invested more in strategies that had better kind of intensity characteristics. And some of the other ones that were floundering more on those dimensions were either let go or they reinvested in ones that were more promising. And so it'll be interesting to see how that happens.
Hey, Samantha, can you guys hear me?
We can hear you.
Yes.
Hi, Jim. This is Fabio Almeida. I'm with Virginia Tech as well. And first, I wanted to thank you for sharing the tool with us. And my question is, I do have a couple questions regarding the scoring. When you showed that one slide that had the different dimensions with the different indicators, and you had the scoring across, which the weights for each category were different. But as I was reading, trying to fastly read some of the descriptions of how you would indicate, yes, the exact one. So for instance, where we have, I believe, let's say effectiveness, and we have evidence, and then you have no evidence to support, minimal evidence, moderate evidence, strong evidence. Now, my question is, how do you distinguish among some of these more subjective in a way? I mean, when we have, for REACH, where we have the numbers 0 to 2%, 2 to 5%, 5 to 13, I think it's more straightforward, while some of these other ones kind of across the dimensions, they look a little more subjective. So I was just kind of hoping to hear from you, what are your thoughts on how potentially we could be thinking of these more, a little more subjective ones here.
Yeah, this is a little bit truncated, so that we could kind of fit it neatly on a table like this. We have a little bit more guidance for the raters on some of these dimensions, such as level of evidence, what minimal means, what moderate means, what strong means, what extremely strong means. So, but you're right. Even with that, there is a subjective quality to it. There's no doubt about it. And it's ultimately, you're an external evaluator making a judgment about that. One of the things that would be really helpful is if there was another team that was doing the same thing to try to calibrate across teams, because my one worry about that is we create to some degree norms around how these things should be rated within a team, and it would be good to have others to calibrate against. But we do have some additional guidance for the raters to try to make some of these things a little bit more, to operationalize some of the ratings a little bit more, and actually replace the more subjective pieces that are in this slide with a little bit of the more objective pieces.
Okay, thank you.
Jim, can you hear me? This is Deborah Tubert.
I can.
I had a question. I wasn't quite able to get a sense of how many of the measures are collected from the staff, the participants in each of these programs versus your staff, and that relates to something that we're struggling with quite a bit when we assess programs in healthcare clinics, the burden of measures. Could you address that a little bit?
Yeah, that was actually, I don't think I mentioned that in the presentation, but another one of the reasons we turn to a tool like this is, so you can imagine these are, most of the community partners are, coalitions and various kind of entities like that, who, often have pretty minimal funding and capacity to do any kind of evaluation. And yet we knew that we didn't have the funding as the evaluators to be able to do true, kind of outcome evaluation or summative evaluation on all these kind of dimensions across all the different kinds of programs. Even now, with the initiative being in its infancy, you could see that list was pretty long. in terms of the interventions that are already happening. So we knew we would never be able to do it, and we weren't hopeful that in the short term, community partners would have really high level evaluation data to lean on. So this is really trying to extract a few important, albeit crude, indicators, even from programs where they have little or no rigorous evaluation data. And we do that by kind of triangulating those three different pieces of evidence. See if I can get to the right slide here. Any documentation, including evaluation, but just even documentation about the nature of the intervention and how they're doing it, and maybe how many people have been served, or some pieces of evidence that we can extract. And then what the scholarly literature suggests about that intervention, or at least ones that are similar to it. And then we talk, and we have a little interview protocol actually that I didn't show you here, but where our students go out and actually interview and try to fill in the gaps of information that we need to rate the tool. So it is decidedly crude information, but we think it is an important increment in information over what we have without it.
Thanks. It's a great presentation. I really appreciated it.
Oh, thank you.
I never want to end it before anyone hasn't had the opportunity to talk, but I think we might be at the end here. I'll give another 20 seconds if anyone has any burning desires. Otherwise, thank you so much, Jim, for sharing this. I really think it's a applicable tool, and I'm sure the members are really appreciative to see this work and the addition of synergy, and I think this is, we can't wait to see what happens.
Thank you.
Jim, could you just show that reference slide one more time?
Yes, I can. Let me see if I can get to it.
And as a brief aside, I'm also going to share that impacts or intensity scoring article that Jim referenced in the blog post on the homepage of the website.
No, that's great.
I've actually, I'm not sure what's going on here, why I can't get to the references now. Let's try again. There we go. So the Kali Acres reference is the reference for the intensity tool that we've kind of incorporated into ours, and on the slides on the actual rating scales, you can see we've also incorporated that tool. Only had 3 indicators, essentially reach, the type of strategy, and then the duration of the intervention. And they happen to actually be different than the ones we had already developed, and so we incorporated those into the appropriate kind of scale on our tool. And on the slides, they're marked with an asterisk.
Okay, with that, thank you so much, everybody, and have a great afternoon.
Bye-bye.
Bye.
Thank you. Thank you so much for putting that together and sharing, Jim.
You're welcome. Thanks for having me. I don't know. I'd be happy to share the slides if you want to send them out. I don't know if there's a mechanism to do that or not.
That would be great. I'll just turn them into a PDF and then include that on the homepage if you're comfortable with that.
Yep, that's totally fine.
Okay. Great stuff. Well, I hope to hear from you soon. And
Yeah. All right. Well, thanks for all your help with making this happen.
Of course. All right. Have a great afternoon.
You too. Bye-bye.
Bye.